Aneuploid fetuses may have severe structural malformations, such as abnormalities of the central nervous system, abnormalities of the face, diaphragmatic hernia, cystic hygroma, heart defects, abnormalities of the gastrointestinal tract, abnormalities of the genitourinary system, non-immune hydrops, and abnormalities of the extremities. Although this may not always apply to cases with Down syndrome, many fetuses with trisomies 18 and 13 have many severe structural defects. The percentage of Down syndrome fetuses with serious congenital defects that can be seen on ultrasonography is only 25% in the second trimester. Cardiac structural abnormalities. Did you know that heart problems, most often ventricular septal defects and common atrioventricular canal defects, affect 50% of infants with Down syndrome? In this image, the fetal heart's apical four-chamber view reveals an inlet ventricular septal defect. A complete atrioventricular canal abnormality in the heart is shown in this transverse axial image of the fetal chest of a fetus with Down syndrome. At the center of the heart, see the single atrioventricular valve, the primum atrial septal defect, and the inlet ventricular septal defect. Not just that, over 90% of fetuses with trisomy 18 and 13 also have cardiac abnormalities. Fetal aneuploidy risk may rise if cardiac abnormalities are detected during prenatal sonography. In fetuses with sonographically identifiable cardiac abnormalities, a substantially greater prevalence of aneuploidy, from 22% to 32%, has been identified compared to postnatal investigations. Compared to isolated ventricular septal defects or valve stenosis, the incidence of aneuploidy is significantly higher for hypoplastic heart, atrioventricular canal defects, tetralogy of Fallot, or double outlet right ventricle. As you can see in this apical four-chamber view of a fetus in the third trimester, a markedly hypoplastic left heart is seen. Now let's talk about duodenal atresia. The double bubble sign, which is a dilated stomach filled with fluid and proximal duodenum, as well as evidence of polyhydramnios, typically used to diagnose duodenal atresia after 20 to 24 weeks of pregnancy. This is a Down syndrome fetus with duodenal atresia. During the third trimester, a transverse axial scan of the abdomen reveals the well-known double bubble sign together with polyhydramnios. In infants, the most common cause of gastrointestinal obstruction is duodenal atresia. Approximately one-third of instances of prenatally identified duodenal atresia have trisomy 21. When prenatal duodenal atresia is identified, invasive karyotype testing has been made available, even if this occurs in the third trimester, since it still gives essential information in counseling patients. Another structural abnormality seen is cystic hygroma. Usually located in the posterolateral region of the neck, cystic hygromas are anomalous cystic masses of lymphatic origin. This is an image of a Turner syndrome fetus with huge, septate cystic hygroma. This gross image is showing massive cystic hygroma surrounding the neck. These cases are highly susceptible to aneuploidy. In fact, more than 60% of fetuses with cystic hygroma are aneuploid. Pay attention, please. The shape and size of the hygroma, as well as the gestational age, all affect the frequency of aneuploidy. This means that large cystic hygromas, which are typically seen after 14 weeks, tend to have septations and carry a high risk of aneuploidy. Approximately 75% of pregnancies in the second trimester are linked to aneuploidy, with Turner syndrome accounting for 80% of these cases. Invasive testing need to be made available if a cervical cystic hygroma is detected during prenatal sonography. Non-immune hydrops. There are several prenatal and maternal reasons that can lead to non-immune hydrops. Ascites, pericardial effusions, pleural effusions, polyhydramnios, enlarged placenta, and skin edema are sonographically identifiable features. Moreover, up to 16% of non-immune hydrops cases can be attributed to aneuploidy. Although the exact cause of hydrops is unknown, it is thought to be related to either lymphatic dysplasia or congestive heart failure. The most common karyotype abnormalities linked to hydrops include triploidy, trisomies 21, 18, and 13, and Turner syndrome. Therefore, invasive testing need to be recommended when hydrops is identified sonographically and seems to be inexplicable. The prognosis is fatal when widespread hydrops and cystic hygroma, also known as lymphangiectasia, combine. In around 2/3 of instances, aneuploidy is linked to lymphangiectasia, particularly in Turner syndrome. So, it must thus be differentiated from hydrops that do not have a cystic hygroma. Now, let's discuss hydrothorax and fetal aneuploidies. Pleural effusion or hydrothorax has been associated with aneuploidy, particularly trisomy 13, Down syndrome, and Turner syndrome. In this image, the heart is pushed to the right side of the chest by a large unilateral pleural effusion that is shown by the asterisk. Therefore, any time hydrothorax is detected on prenatal sonography, fetal karyotype analysis must be made available. Diaphragmatic hernia. The cause of a diaphragmatic hernia is a congenital abnormality in the fetal diaphragm that causes the abdominal viscera to herniate into the fetal chest. A transverse image of the fetal chest reveals a diaphragmatic hernia on the left side. The heart is shifted to the right side of the chest cavity, revealing the stomach, bowel, and liver. Chromosomal abnormalities such Down syndrome, Turner syndrome, trisomy 18, which is the most prevalent, trisomy 13, and other abnormalities are more likely to occur in people with this abnormality. Therefore, any time this abnormality is discovered during pregnancy, karyotype testing need to be made available. Now, let's discuss Omphalocele. When there is a central abdominal wall defect, intra-abdominal tissues herniate into the membrane-covered base of the umbilical cord, resulting in an omphalocele. In this image there is a large liver in a fetus in the second trimester with omphalocele. Also note that the omphalocele exceeds the size of the original fetal abdomen. In over half of the instances that are detected prenatally, omphaloceles are linked to other fetal abnormalities that include aneuploidy. Whenever an omphalocele is detected, patients should be offered invasive karyotype testing. Also note that the risk of aneuploidy is greater in omphaloceles with intracorporeal liver than in those with extracorporeal liver. Now, let's talk about cerebral ventriculomegaly. A frequent diagnosis is cerebral ventriculomegaly, which is identified when the atrial diameter of the cranial lateral ventricle exceeds 10 mm or greater. This is frequently related to the choroid plexuses, dangling, or relative shrinkage, or the inability to completely fill the lateral ventricle's diameter. Even mild ventriculomegaly raises the possibility of developing aneuploidies like Down syndrome. In contrast, it could also be observed as a typical variation in male fetuses, and later in the second trimester, after 20 weeks of gestation, when there is no choroid plexus dangling. Agenesis of the corpus callosum. The agenesis of the corpus callosum may be complete or partial. The lack of the complex made up of the corpus callosum and covum septum pellucidum, in addition to other sonographic abnormalities such as colpocephaly, are all indirect signs for the diagnosis. This fetal ultrasound shows agenesis of the corpus callosum. Arrows point to the widely spaced frontal horns with absence of the covum septum pellucidum. Agenesis of the corpus callosum can be detected by a disproportionate expansion of the occipital horns, Holoprosencephaly, shown with the asterisk, or the typical teardrop sign of the lateral ventricles on a transverse axial scan across the ventricle. Aneuploidy is found in approximately 20% of cases, and mostly include trisomies 18, 8, and 13. Holoprosencephaly. A brain condition known as holoprosencephaly is caused by partial or incomplete division of the prosencephalon, or embryonic forebrain, and inadequate creation of the midline structures. Holoprosencephaly is a brain disorder characterized by insufficient formation of the midline structures and partial or incomplete division of the prosencephalon, or embryonic forebrain. Alabar, semilobar, and lobar types are the three main forms of holoprosencephaly, which vary in terms of the degree of anatomic abnormality. Of fetuses with alabar or semilobar holoprosencephaly, 50% to 60% have aneuploidy overall. Trisomy 13 or a variation of trisomy 13 is the most prevalent form of chromosomal abnormality, accounting for 50% to 75% of individuals with aberrant karyotypes. However, a wide range of additional aneuploid types have also been documented. This is a transaxial image of a trisomy 13 fetus's head reveals alabar holoprosencephaly. A single monoventricle, referred to by the asterisk, encircles the fused thalami, referred to by the letter T on the image. There have been reports of holoprosencephaly in 39% in fetuses with trisomy 13. The risk for aneuploidy is higher when holoprosencephaly is combined with extrafacial or facial abnormalities. And this finally takes us to facial anomalies. Fetuses or newborns with karyotypic abnormalities frequently have facial malformations. A flattened profile, sloping forehead, retrognathia, or micrognathia are possible signs of some karyotypically defective pregnancies or newborns. This sagittal scan shows severe micrognathia in an abnormal facial profile, referred to by an arrow. Cleft lip and palate. Did you know that cleft lip and palate has been associated with aneuploidy, especially trisomy 13 and 18, particularly when it coexists with other anomalies or deformities of the central nervous system? This is an illustration of the fetal face in 3 dimensions that shows a unilateral cleft lip. Another 3-dimensional image of the fetus's face displaying bilateral cleft lip. According to a recent study, aneuploidy was found in 0%, 32%, 59%, and 82% of fetuses with unilateral cleft lip and palate, bilateral cleft lip and palate,
Excess soft tissue in the posterior neck region or redundant nuchal skin folds are seen in 80% of newborns with Down syndrome. A 21-week fetus with Down syndrome has an increased nuchal skin fold thickness, 10 mm, as seen by a transaxial plane into the fetal head's posterior fossa. In this sonogram, the second trimester's typical nuchal fold thickness, as seen from the posterior fossa, is 0.41 cm. The difference between both nuchal fold thickness is quite obvious. Other chromosomal disorders including Turner syndrome, trisomy 18, and 13 also show nuchal thickening. In certain instances, it can even be the result of the resolution of a cystic hygroma. Benacerraf was the first to identify trisomy 21 sonographically in 1985 by describing enlarged soft tissue in the fetal occiput between 15 and 20 weeks of gestation. The authors reported that a nuchal fold thickening of more than or equal to 6 mm was present in 33% of fetuses with Down syndrome. The thickness of the nuchal skin fold can be obtained by passing a transaxial plane across the fetal skull and angling it posteriorly to include the occipital bone and cerebellum. The cisternum magna, cerebral peduncles, cerebellar hemispheres, and cavum septum pellucidum are important internal anatomic landmarks. Calipers are used to measure from the exterior skull table, or outside the occipital bone, to the outer skin border. Measurements are usually taken between weeks 15 and 21 of pregnancy. Values of greater than or equal to 5 or 6 mm are considered abnormal or increased. Although it has recently been demonstrated that absent nasal bone has 41% sensitivity and 100% specificity for fetal Down syndrome, the thickened nuchal fold is one of the most significant marker and the most sensitive and specific single marker for the mid-trimester detection of Down syndrome. In light of these findings, even in low-risk populations, genetic amniocentesis need to be made available whenever an abnormal nuchal fold measurement is detected. It's crucial to remember that while some trisomy 21 fetuses may experience nuchal thickening during the second trimester, other fetuses will completely resolve. An amniocentesis should be offered as soon as an abnormal nuchal skin measurement is obtained, regardless of whether the nuchal skin thickness resolves, because regression may occur whether or not the fetus has Down syndrome.
The tendency for the second trimester Down syndrome fetus to have short humerus and femur bone lengths is not surprising, as trisomy 21 individuals frequently have short stature. It has been demonstrated that the short limbs, which are out of proportion to the head circumference, are the most noticeable deviations from normal in the somatic and visceral growth profiles of second trimester trisomy 21 fetuses. It is crucial to measure long bone lengths with the diaphysis horizontal in the image, since vertical measurements may mistakenly shorten the length. Instead of using gestational age, the most common technique for calculating short-long bone length is to compare the actual measurement with the predicted value based on biparietal diameter. The relationship between a short femur and a higher likelihood of prenatal Down syndrome was first shown in 1987. Either the observed to expected femur length ratio or a BPD to femur length ratio can be used to assess the femur length between 15 and 23 weeks. Trisomy 21 fetuses have slightly shorter femurs than normal fetuses, according to the majority of evidence. However, this decrease is relatively small, and it could not be helpful as a standalone screening for Down syndrome. As with other sonographic aneuploidy indicators, it is therefore more useful to use a combination of markers rather than one in isolation to identify fetal Down syndrome. Fetuses with both a short humerus and short femur carry an 11-fold higher risk of having trisomy 21, when compared with the age-based risk. False positive rates can be significantly decreased by combining measurements of femur and humerus length. Compared to the age-based risk, fetuses with both a short humerus and a short femur have an 11-fold increased risk of having trisomy 21.
Renal pyelectasis, also known as renal pelvic dilatation, is assessed in an anterio-posterior dimension of the fluid-filled renal pelvis. Measure the renal pelvis when the kidneys and spine are directly toward or away from the transducer, rather than to the side. The abnormal cutoff varies, but the most common value used is an anteroposterior diameter of 3 to 4 millimeters. Pyelectasis has been linked to an increased incidence of aneuploidy, particularly trisomy 21. The frequency varies with gestational age, and many instances resolve as the pregnancy progresses. Prenatal sonography often detects moderate pyelectasis in 2% to 2.8% of normal fetuses. While isolated fetal pyelectasis is a sonographic marker for trisomy 21, it is unlikely to recommend amniocentesis in a low-risk group. In high-risk populations, pyelectasis may be used in conjunction with other aneuploidy markers, such as nuchal fold and short-long bones, during sonography. Pyelectasis may increase the incidence of fetal trisomy 21 in high-risk mothers, even if it is present alone.
A common finding during second trimester sonography is an echogenic intracardiac focus, which occurs in 3 to 4% of healthy fetuses. It is a distinct, strongly echogenic spot that resembles bone in brightness and seems to be brought on by reflection from the chordae tendineae and papillary muscles. According to pathologic correlation, echogenic intracardiac focus is associated with the mineralization of papillary muscles, which may be shown histologically. It could also be an example of myocardial fibrosis around coarse intramyocardial calcifications. The existence of an echogenic intracardiac focus is not linked to cardiac abnormalities in low-risk people. Asian patients are 3 times more likely than white patients to have echogenic intracardiac focus, suggesting that the condition is far more common in the Asian community. Due to the possibility that echogenic intracardiac focus is a subjective finding, its identification is dependent on a number of factors, including fetal position, maternal scanning characteristics, the sonologist's expertise, the ultrasound machine's quality and resolution, the thoroughness of the examination, and sonographic method. It is most clearly apparent in an apical 4-chamber view, with the apex facing towards or away from the transducer, since it may disappear when observing the heart from a subcostal or transverse 4-chamber view, when apex pointing sideways. Multiple or large echogenic intracardiac foci may raise the likelihood of aneuploidy. An echogenic intracardiac focus in the right or both ventricles may increase the risk of aneuploidy compared to a single focus on the left side. The association between an echogenic intracardiac focus and trisomies 21 and 13 has been proven in literature. An isolated echogenic intracardiac focus in a high-risk population increases the pre-existing risk of fetal Down syndrome. In low-risk populations, if the echogenic intracardiac focus is isolated and there are no other major or minor sonographic abnormalities, it is considered a normal variant, and no additional testing, including fetal karyotyping, is recommended.
Echogenic bowel, like many other aneuploidy markers, is nonspecific and can occur in normal fetuses. Approximately 0.5% of normal fetuses have this finding, making it uncommon. Normally, during the second trimester, the bowel is homogeneous and echogenic like the rest of the fetal abdomen, making it unnoticeable. Echogenic bowel might be seen as abnormally echogenic. The clinical significance varies according on the degree of echogenicity. To minimize subjectivity in clinical identification of echogenic bowel, some have implemented a grading system. Some will only recognize intestine that is significantly echogenic on sonography, whereas others will detect both moderately and markedly echogenic bowel. The recommended grading system for echogenic bowel is as follows. Grade 1 is mildly echogenic and often diffuse, Grade 2 is moderately echogenic and typically focused, and Grade 3 is extremely echogenic, comparable to bone structures, preferably the iliac bones. Echogenic bowel is more frequent in aneuploid fetuses, especially those with trisomy 21. In this sonogram, a Down syndrome fetus with echogenic bowel, referred to by arrows, in the fetal abdomen, and it is classified as Grade 3. As you may note, echogenicity is quite similar to that of the vertebral bodies of the fetal spine. Echogenic bowel may raise the risk of trisomy 21 by 6 to 7-fold. However, the risk varies according on maternal age, existence of other structural abnormalities, and other risk factors. The risk of Down syndrome in isolated echogenic bowel ranges from 1.4 to 2%. Echogenic bowel can be caused by congenital infections, for example, cytomegalovirus, herpes simplex virus, and parvovirus. It can also be due to cystic fibrosis-induced meconium ileus, or intestinal obstruction or atresia or malformations. Echogenic bowel should not be confused with meconium peritonitis, which is identified by peritoneal calcification on prenatal sonography. Please note that echogenic bowel differs from hyperechoic meconium found in the third trimester, which is often limited to the colon. Therefore, when an echogenic bowel is detected, it is important to conduct maternal studies for congenital infection, cystic fibrosis carrier status, invasive testing for fetal karyotype, and serial scans throughout the pregnancy to rule out intrauterine growth restriction and bowel malformations or atresias, which may not be visible until the third trimester.
The cerebral lateral ventricles have sonolucent cerebrospinal fluid. The lateral ventricles contain the brightly echogenic choroid plexus, which typically fills the atrium and may include cysts. With today's enhanced sonographic equipment and clarity, choroid plexus cysts are a quite common observation during the second trimester. Choroid plexus cysts are generally benign and have no known impact on fetal development. Choroid plexus cysts seem to be transient and are virtually only observed in fetuses between 16 and 21 weeks of gestation. It is rare to see them sonographically after 25 to 26 weeks of gestation, since they are often undergoing regression by the 23rd week. Cysts can be small or large, unilateral or bilateral, and solitary or multiple. The cysts are usually between 0.5 and 2 centimeters in size, and they frequently have a multilocular appearance. On rare occasions, they might be so big that they fill practically the whole lateral ventricle and enlarge its walls, creating the appearance of ventriculomegaly. Because choroid plexus cysts have been linked in the literature throughout the years to fetal aneuploidy, particularly trisomy 18, they can be a noteworthy discovery. Roughly 1/3 of trisomy 18 fetuses seem to have choroid plexus cysts. The question of whether fetuses with choroid plexus cysts on ultrasonography should have karyotyping done is hotly debated because of this link. Invasive testing should be made available to fetuses with choroid plexus cysts if additional sonographic abnormalities are present. Management should be cautious, nonetheless, if skilled professionals' prenatal sonography shows that the choroid plexus cysts are isolated. According to some researchers, fetuses with isolated choroid plexus cysts and no other abnormalities may nevertheless be at high enough risk of aneuploidy to warrant amniocentesis. But the key question is whether a choroid plexus cyst that is labeled as isolated is indeed isolated. Only after a thorough prenatal examination by qualified experts has failed to identify other structural abnormalities or indicators can this be assumed. All fetuses with choroid plexus cysts must thus have a thorough fetal sonographic anatomic assessment performed by a qualified and competent prenatal diagnostician. Therefore, when choroid plexus cysts are visible sonographically, we think a comprehensive, detailed evaluation of the remaining fetal anatomy is necessary to rule out additional anomalies and raise or lower one's suspicion of aneuploidy. According to our experience, invasive testing is not necessary if no more abnormalities are discovered because the chance of aneuploidy is quite low, even in high-risk patients.
In 1866, when Langdon Down initially reported the characteristics of patients with trisomy 21, he observed that the nose was small and the face was flat. This is a typical characteristic of fetuses with Down syndrome. This ultrasound shows the characteristic facial features of Down syndrome, including a small nose and a protruding tongue. As a more objective proof, radiographs of fetuses with Down syndrome have also shown absent ossification, hypoplastic or short, and agenesis of the nasal bone. Keeling et al. Used radiography to analyze 31 Down syndrome babies, between 12 to 24 weeks, and discovered that 61% of them had nasal bone hypoplasia or agenesis. Fetal Down syndrome has been associated with nasal bone hypoplasia, or absence of nasal bone on ultrasonography. It is important to use the correct technique and angle of insonation while assessing the nasal bone's facial profile. It is important to examine the profile in the mid-sagittal plane, keeping the angle of insonation between 45 and 135 degrees. It is advised to use this method to prevent inadvertently obtaining inaccurate nasal bone measurements. The nasal bone may look artificially absent at angles more than 135 degrees or less than 45 degrees. However, due to echo dispersion, it may become harder to distinguish the exact margins of the bone as the angle gets closer to 90 degrees, and the measurement may become unnaturally large. If you employ the proper approach outlined above, you should see the nasal bone as a linear echogenic structure. When absent nasal bone was added to the other sonographic aneuploidy markers, the sensitivity of genetic sonography increased from 83% to 90%. Thus, this marker has been included in the list of sonographic aneuploidy markers assessed during a genetic ultrasound examination since 2003. Absent nasal bone is an ideal marker to add to other traditional markers assessed during genetic sonography since it has a very high specificity, and accordingly low false positive rates, and does not increase the false positive rate. Nasal bone length's correlation with other sonographic markers may increase sensitivity and lower the false positive rate for fetal trisomy 21, preventing unnecessary invasive procedures. Nasal bone presence or absence is presently used as a sonographic marker for aneuploidy, and examiners have demonstrated 100% agreement on this point. A short nasal bone was linked to an increased risk in a high-risk group, whereas absence of a nasal bone was a strong marker of the trisomy 21. Therefore, measuring nasal bone length in the second trimester can provide more benefits than simply determining the presence or absence of the nasal bone.
Clubfoot is often connected with spina bifida, however it can also be linked to aneuploidy, such as trisomies 18 and 13. Some studies showed that isolated clubfoot cases may require invasive karyotype investigation, leading to some debate. Nowadays, it is very well accepted that, after a normal prenatal ultrasonography and a low-risk patient, fetal karyotyping is not recommended for isolated unilateral or bilateral clubfoot. Rocker bottom foot is characterized by a rocker bottom appearance on sonography, like the bottom of a rocking chair, rather than the typical inward arch of the plantar surface. This may be detected in aneuploidies such trisomies 18 and 13. Clinodactyly is characterized by a curve inward or deviation of the fetal hand's fifth digit toward other fingers. In a radiographic postmortem examination, it was observed in around 1/3 of cases, including those with Down syndrome. While clinodactyly is commonly associated with prenatal Down syndrome, it's important to note that it can also be present in normal fetuses. Clinodactyly, unlike thicker nuchal folds or pyelectasis, can be more subjectively interpreted. Although this marker may be useful for high-risk patients, its high false positive rate makes it unsuitable for screening purposes. The sandal gap abnormality in a fetus with Down syndrome was first reported in 1994. Prenatal sonography may reveal a broad distance or gap due to separation of the big and second toes. Sandal gap, like clinodactyly, is a common feature in normal fetuses, making screening difficult. Aneuploidy, particularly trisomy 18, has been linked to limb reduction abnormalities, including radial aplasia. When radial aplasia is detected, trisomy 18 should be considered in the differential diagnosis. Trisomy 18 is often associated with mobility problems and flexion deformities. This chromosomal anomaly is characterized by persistent flexion of the hands, resulting in overlapping digits. Some trisomy 18 fetuses have global arthrogryposis or contractures. Polydactyly refers to the presence of more than 5 digits. Extra digits on the radial or tibial side are categorized as preaxial, whereas those on the ulnar or fibular side are considered postaxial. This additional digit might be a skin tag, a bone, or a duplicated non-functional digit. Polydactyly is commonly found in fetuses with trisomy 13.
The typical umbilical cord has 3 vessels, 2 arteries and 1 vein, wrapped with Wharton's jelly. The absence of one umbilical artery, single umbilical artery or 2-vessel cord, is the most prevalent pathologic condition of the umbilicus in humans and one of the most common malformations. This sonogram shows only 2 vessels, the larger umbilical vein and the smaller umbilical artery. Prenatal detection involves checking the umbilical arteries that flow alongside and around the fetal bladder in a transverse view of the pelvis. Color flow Doppler or power Doppler imaging appears to be the most effective screening approach for single umbilical artery. Approximately 17% of fetuses with a single umbilical artery have chromosomal abnormalities, with almost half exhibiting severe defects. Trisomy 18 is the most prevalent aneuploidy linked to single umbilical artery. Single umbilical artery is commonly linked with aberrant karyotypes such as trisomy 13, Turner syndrome, 45X, and triploidy. Fetal abnormalities linked with single umbilical artery can vary from 18.4% to over 47%, with pathologic investigations showing the greatest prevalence of deformities. When a single umbilical artery is diagnosed, it's crucial to do a thorough prenatal anatomic survey to rule out any other anomalies. To summarize, identifying single umbilical artery sonographically should lead to a search for further abnormalities. However, in low-risk patients, the discovery may not warrant chromosomal investigation alone. Patients should also be aware that newborns may have modest defects that can only be detected at birth.